So first of all, I'm very honored to introduce Professor Massimo Colombo. Professor Massimo Colombo is the director of the Liver Center of the IRCCS San Raffaele Hospital in Milan, Italy. He is also a chairman of the ISHO International Liver Foundation, Genoa, Switzerland. His research fields include the diagnosis and the treatment of the viral hepatitis, hepatocellular carcinoma, and the liver transplantation. He is a member of the several professional associations and the society, including the American Association for the Study of the Liver Disease and the European Association for the Study of the Liver and other international and the Italian Association. He has published more than 800 articles in the national and international peer-reviewed journals, and with Asian index of 89. More recently, one of the articles from Professor Colombo has got the rapid citation. The viral hepatitis as a risk factor for the development of hepatocellular carcinoma. We'd like to invite Professor Colombo to share his insightful views on this topic, on this article, and recent research. Here are the outline of the questions. Question 1. You recently published a paper entitled Viral Hepatitis as a Risk Factor for the development of the hepatocellular carcinoma, in which you mentioned that the implementations of the anti-cartilage interventions of the sanitation making reach the WHO goal of viral eliminations more realistic in some small countries like Georgia and the Iceland. However, it is difficult even to identify hepatitis carrier in the large countries. What do you think these large countries can do to improve these situations?
Okay, thank you for your question, Professor Cao, and for the nice introduction, and good morning also to Victoria, who is a very strong chaperone in these cultural initiatives, Victoria. Okay, I can share with you my own experience here in Italy. In Italy, we were able to have a drop in the prevalence of hepatitis C infection in the general population, as you anticipated, through a number of sanitation initiatives. You are aware of it. But still, there is a kind of a reservoir of chronically infected patients, mainly those without symptoms and signs of chronic liver disease. In the past 7 years, we were able to treat more than 250,000 patients with advanced liver disease who might, by default, were well identified and known because attending liver centers in Italy. And thanks to DAA therapy, we got an extraordinary rate of cure greater than 98%. Now the issue comes what to do with the rest of the Hep C reservoir in Italy. We have done a small study in Milano, testing for hepatitis C persons who were attending the vaccination program against COVID. And we focus on patients age that were born, or if you wish, belonging to the birth strata, birth cohort, 1969-1989, on the hypothesis that these strata of our population could still be heavily infected by hepatitis C, because as it happened in China and in Far East, most of the infections of hepatitis C had been brought about around by unsterilized syringes and dirty needles in the home health care activities, injections, in other words, okay? And in the past, unchecked blood transfusion as well. Well, in Milan area, 0.04% of the population carried viremic infections, and 80% of them were ethnics. In other words, migrants from Africa and Asia. So our conclusion was, at least in the Milan area, we should avoid testing massively the birth cohort 1969, 1989, but we should move deeper, testing the cohort 1949, 1969. And that is what is exactly we're starting to do here in my hospital. We have received a grant to start investigating the hepatitis C infection among these strata of the population. So I believe that in Italy, the youngest population and the middle-aged population basically are hepatitis free, Hep C free, with the exception, of course, of persons with risky behaviors, homosexuals and drug users. The rest of the population is, generally speaking, safe. The aged population born between 1949 and 1969 need to be investigated, because we predict that there could be 1% of the population carrying hepatitis, still carrying hepatitis C.
Second question is, do you believe that hepatitis B virus can be eradicated in the next decades? If so, what is the best option to do this? Specifically, what kind of the strategies can be applied to eradicate the infection of HBV in African countries and other developing countries in the world?
Now, this is a question that I love mostly because I was personally engaged in the writing of the guidelines for developing mandatory vaccination against hepatitis B of newborn some more than 30 years ago. But you know, when I wrote the protocol for the Ministry of Health, I made a terrible mistake. I was just copying the Chinese scheme to vaccinate newborns only. I was amended because a close friend of mine who was a public health expert, I'm a clinician, you know what I mean? He was a real public health expert, introduced the parallel vaccination of 12 years old infants. For 12 years, we kept on vaccinating all the newborns and all the 12 years old boys. So in 12 years, we got the Italian population between 0 and 24 years covered by Hep B vaccination. And that prevented spread of hepatitis B through sexual activities and drug injections, and was particularly effective in blocking the spread out in the general population of hepatitis delta. Because, you know, in Italy, like in China, and particularly in the southern part of Italy, we used to have large families with more than one member chronic carriers of hepatitis B. And when hepatitis delta entered the family through sexual behaviors, intercourses, or drug user, it was a tragedy. A lot of fatal acute fulminant hepatitis delta were generated that, you know, is untreatable unless you transplant your patients. So we start more than 30 years ago vaccinating newborns and 12 years old people, infants, for 12 years. And subsequently, we kept on vaccinating newborns only. As a matter of fact, we dropped, if you wish, from 3.5% rate of infection among the general population, adult general population, to less than 1%. And again, a majority of the chronically infected hepatitis B are ethnics. So we were able to curb the infection among the general population. And I tell you that in Europe, we were not followed at all, because the other countries that came later, starting vaccination against hepatitis B, they focus only on newborns. And as a matter of fact, today, hepatitis B accounts for the higher rate of hepatitis B-associated liver cancer in Northern Europe, because it has been spread through sexual contacts and drug use. So these countries, UK, Germany, France, Norway, upper northern of Europe, Poland, they should refine their strategies, in my opinion, introducing vaccination in parallel of 12 years old. What do we do for patients who are carriers of hepatitis B? We have a large number of population that is under chronic nuke therapy. The most popular is tenofovir, but also entecavir has been distributed in Italy. And with the generics now, it is a very cheap modality of suppressing hepatitis B. Unfortunately, as you perfectly know, the risk of hepatocellular carcinoma is still there, particularly for people aged more than 45, and those who start therapy being cirrhotic. Not to speak about those with special comorbidities, at least in Italy, obesity, alcohol abuse, and diabetes. They increase significantly the risk of HCC in chronic hepatitis B being suppressed by nuke. Now, you ask me, what do I think about the new treatments that are upcoming? I think it is a large waste of money, because in my personal opinion, nothing is better than nukes. They have been shown to be very effective, and chronic suppression of DNA is the key to prevent decompensation, and in those patients who start being treated prior to developing significant fibrosis of the liver, also for preventing liver cancer. Currently, there are a couple of new regimens that look promising. In my personal opinion, particularly the ASO regimen that show to be active through a toll-like related mechanism that recalls me about our friend interferon, because interferon used to be a perfect modality to treat, but difficult to manage and toxic to many patients, unfortunately. The new regimens that are being developed with the goal of eliminating HBs antigen, I'm not sure that they do represent the ideal treatment modality. Currently, the ideal treatment modality is chronic administration of nuke. Maybe tomorrow, if we will be in a position to eradicate CCC DNA, we might have new regimens that are really promising. Today, the real promising regimen, in my opinion, is ASO, which is acting through activation of the toll-like receptor, so in a modality that looks like interferon.
Third question is, in the past 3 years, the COVID pandemic have put in major pressures on the public health systems around the world. Can you talk about the impact of the COVID on hepatitis eliminations? Do you think we can achieve the goal of the elimination hepatitis B by the end of the year 2030?
My dear friend, COVID was a disaster, not only in Italy and not only in Europe. We have calculated the COVID pandemic prevented effective strategies of viral hepatitis B and C elimination with the accumulation of more than 100,000 deaths due to hepatitis C only. So the goal of 2030 is not reachable at all, and was not reachable at all even if pandemic did not exist. And the reason is very simple. There are no programs in the developed and the underdeveloped and in the less developed countries for mass screening of viral hepatitis going forward. And this is the first point. Second, there is a weak political will to eradicate hepatitis C and hepatitis B. And I tell you frankly, because of stigmas. You know, carriers of viral hepatitis are misunderstood as being all drug users, all alcoholics, or persons with bad behavior, which is not absolutely the case. 99% are regular persons, are general population. But there is a weak political will to fight hepatitis B and hepatitis C related morbidity. Third, money. I think that today we dispose of cheap regimens to treat hepatitis C and hepatitis B, but in the Western world, therapy of hepatitis C is still costly. In Germany, it costs a fortune. In Italy, it costs $4,000. You know what I mean? In other countries, you know, generics cost nothing. In Egypt, it costs $50. So there are huge discrepancies in the cost of treatment. Fourth, and this is last but not the least, there is a large strata of an affected population which is unreachable. Think about the people living in Africa. Africa is an enormous continent. How can you reach out to those people in the forest, in the jungle, in the dispersed areas? How can you reach out the core of China itself? China is an immense country with a large area which is not populated by cities. Countryside is enormous effort to reach out them. And what about South America? The Andean populations. So I still believe that there are three good reasons for saying that the 2030 endpoint of WHO program will never be reached out. I'm very doubtful about this, my dear friend.
Because of the, you know, this pandemic, probably people do not have enough money to support that kind of elimination. So the government is supposed to invest a lot of medical insurance for this, but I'm not 100% sure. This is happened here in this country, in China. Okay, because the insurance was covered, most of the insurance is covered by the government. But for the developing countries, for the African country or the other lower income countries, probably this is a big challenge. As you said about in different countries, in Germany, in Italy, several $1,000s, in Egypt, $50. So this is according to different kind of, you know, the support of the government or the price of this antivirus agent. So it is very, very interesting.
Yeah.
And okay, we're gonna the fourth question. So we are quite interested in your research interest now. So what are your research interests in this year or in the next few years? Would you mind to share this with us? So what's your very,
we have,
you know?
Yeah, thank you. Let me just add on a comment on viral hepatitis elimination. You know, first of all, China enjoys a huge and mass social program. You are a socialist country, and you have in your heart the well-being of your population as a first aim of your political activity, which is not necessarily true. I'm saying this softly, not to be arrested, which is not necessarily true elsewhere. You mentioned Egypt. They did a tremendous effort to eradicate hepatitis C. But you know what is happening? They are reinfecting their patients because they do not dispose of disposable needles and syringes. So the issue there is the lack of sanitation activities in the rural area. Because, you know, in Egypt, between us, 30% of the population is concentrated in Cairo, and the rest is dispersed in the countryside. So, you know, in the countryside, sanitation against viral hepatitis is difficult. They do not dispose of disposable needle and syringes, but this is just a comment. So going back to my program of research, we have 3 lines of research. First of all, here we have approximately 50 resections of liver of HCC per year and 50 resection of cholangiocarcinoma per year, plus an enormous amount of HCC and CCA, which do not fit the criteria of surgery, particularly HCC not fitting the criteria of liver transplantation. In Milano, 50% of liver transplantation is carried out to treat alcoholic liver disease. So the first topic of research is cholangiocarcinoma, early diagnosis. And we have in Europe identified certain risk factors. For instance, for CCA, one important risk factor is obesity and diabetes. Whereas for the rest, you know, clastic tumor is, of course, PSC, and choledocholithiasis is an important risk factor for distal cholangiocarcinoma. Cholangiocarcinoma is on the rise in Europe and becoming important. The second topic that we are addressing is how to identify the natural history of HCC in SVR patients undergoing ablation or resection when they recur. Currently in Italy, we do not know what to do when HCC recurs in an SVR patient. In other words, some center will perform liver transplantation if there are the age-related and morbidity-related criteria are in place. In other centers, possibly those with the less transplantation volume are keen to re-resect or re-ablate. So we wish to understand better the natural history of HCC in SVR with the focus on recurrence after ablation, after resection. The third important point to be explored by us this year is liver disease related to metabolic syndrome. In my hospital, there are more than 5,000 patients with diabetes, type 2 diabetes, and we are currently exploring the way to run cost-effective screening for cirrhosis and liver cancer. And you are perfectly aware that this is a huge problem because for a number of reasons, we do not dispose of very effective modality. We currently combine FIB4 non-invasive test, FIB4 plus FibroScan or shear wave elastography to identify patients with advanced liver disease, and subsequently these patients are subjected to screening every 6 months with abdominal ultrasound, or in difficult cases because of obesity or excessive steatosis with fast MRI.
So, you know, the cholangiocarcinoma is very malignant. So do you think it makes sense to perform the earlier diagnosis? I mean, earlier or later? They also, but I don't think have any big difference related to the prognosis.
Yes,
I think that the most important way in my mind is you probably need to identify the risk factors and prevent the occurrence of disease, especially for the obesity and something like this. It agrees with me?
I can only answer based upon European experience. At the ILC meeting of ISL in London last June, the ENS, the European Network for Cholangiocarcinoma, presented a study of more than 2,500 cases of cholangiocarcinoma that have been collected throughout Europe. The majority, 60%, were intrahepatic cholangio. Most of them were mass forming. And the rest was split into half, proximal and distal cholangio. Well, 50% of all these cholangio were resectable. The rest were late onset, late diagnosis tumor with no chances of being resected. And you are perfectly aware that lymphnodal spread is the main reasons for unresectability, followed by intrahepatic spread of metastasis. So if we are able to detect the tumor in the very early phase, when lymph nodes are spared and there is no massive spread into the liver, we can reach out easily more than 5 years survival in 50% of the cases. Of course, with the help of new adjuvant and adjuvant chemotherapy based on platinum. For those not responding or recurring after platinum, there are chances, if they carry special molecular alteration, IDH1 or FGFR fusions, there are 2 regimens that prove to be able to prolong significantly their survival. So we are betting that increasing early diagnosis through the identification of people at risk, we can significantly increase patient survival. Not to speak about the fact that when we screen patients with cirrhosis, 10% of the nodules in cirrhosis that show up with wash-in, wash-out at MRI are in fact small mass-forming cholangiocarcinoma. And when they are less than 2 centimeters, they can safely and effectively undergo liver transplantation. So, you know, Professor Cao, we are rather optimistic that this fatal disease can be to some extent counteracted through early diagnosis.
Yeah, sure. Sure, I agree with you about this. And do you think that there's some kind of flag infection in European countries? I mean, the flag, the cause of the cholangiocarcinoma in Thailand, and in Thailand, in the south part of China, we have that kind of the infection.
Yeah.
Only infected about the duct, the bile duct, and supposed to be the major cause of cholangiocarcinoma. So I don't think the European people have that kind of infection.
Well,
I tell you, what's the major reason?
We believe that the vast majority of cases that are considered to be cholangiocarcinoma on the rise in Europe is a kind of a diagnostic drift. We learned more about this form of cancer. We are looking after it, and we are able to detect earlier because we have improved detection in the liver and staging in the lymph nodes. We don't think that flukes are important. We do think that certain congenital disease of the ducts are to some extent engaged in the distal forms of cholangio, not necessarily in the intrahepatic, which represent 60% of all the cholangio that we see in Europe. So at variance with Far East, where flukes are dominant cause of cholangio, here cirrhosis, diabetes, obesity, maybe alcohol are most engaged with the intrahepatic forms of cholangio. This is our gut feeling. Gut feeling, Professor.
Thank you very much, Professor.
It will be a great pleasure to interact with all of you. China is in my heart. The civilization of the world starts from China and Egypt, and I don't forget this. Stay well, thank Professor. Bye-bye, and thank you so much for this very nice interview.
Thank you. Thank you.